Welcome back, everyone. Today we are diving into a tiny piece of anatomy that carries a massive weight in the clinic. We are talking about the recurrent branch of the median nerve. Dr. Sarah, I've always called this the $1,000,000 nerve. Is that still showing up on the boards?
It absolutely is, Dr. Khan, though the boards might use the more formal thenar branch or recurrent branch. It is a high-yield favorite because its location is so specific and its function is so vital for what makes us human, the ability to use our thumbs.
Exactly. Think about it. Without this tiny nerve, your hand is basically a flipper. You lose that pincer grip. I like to tell my students to imagine the median nerve is like a major highway running through the carpal tunnel. But then, right at the end, it realizes it forgot something and makes a sharp U-turn back toward the thumb. That's the recurrent branch.
That's a perfect analogy. To be precise, as the median nerve exits the carpal tunnel, distal to the flexor retinaculum, this motor branch recurs or loops back. It's incredibly superficial, which is the academic point to hammer home. It lies just beneath the skin and palmar fascia.
And that is exactly why it matters clinically. Because it's so shallow, even a minor oops in the kitchen can be life-changing. I once saw a patient who dropped a glass, tried to catch it, and got a tiny 1 centimeter laceration right at the base of the thenar eminence. Dr. Sarah, what did that patient lose?
Well, for the boards, you need the OAF mnemonic. That's OAF for the thenar muscles. The O is for opponens pollicis, the A is for abductor pollicis brevis, and the F is for the superficial head of the flexor pollicis brevis. If you snip that recurrent branch, you lose those three.
OAF. I love it. Simple and effective. Now, clinically, when those muscles go, the thumb just falls flat. It's no longer opposable. It sits in the same plane as the other fingers. We call this ape hand. It looks just like it sounds, a hand that can't grasp a pen or a coffee cup properly.
And that's a critical distinction for exams. Students often confuse ape hand with the hand of benediction, or Pope's blessing. Remember, ape hand is a distal lesion of the median nerve at rest. The hand of benediction is what happens when you ask a patient with a proximal median nerve injury to make a fist.
Great point. Proximal versus distal is everything. Why does this matter clinically? Because if I see a patient with a palm laceration and they can't touch their thumb to their pinky, I'm not just looking at a skin tear, I'm looking at a neurosurgical emergency to save that thumb function.
Right. And because the thumb accounts for nearly 40 to 50% of overall hand function, any surgeon working in that area has to be the doctor of choice for hand precision. You cannot afford to be reckless near the thenar eminence.
That $1,000,000 nickname comes from the fact that historically, if a surgeon accidentally nicked that nerve during a carpal tunnel release, the malpractice payout was enormous. It's a small target with a huge price tag.
Speaking of carpal tunnel, we should clarify. The recurrent branch usually branches off after the tunnel, but there is anatomical variation. In some people, it actually pierces through the flexor retinaculum. That's a classic Chap question on the USMLE.
The human body loves to keep us on our toes with variations. So let's paint the picture for the listeners. You have a patient who can feel their thumb just fine because the sensory branches are deeper or separate, but they can't move it into opposition. That motor-only deficit is the hallmark of a recurrent branch injury.
Exactly. Sensory is intact because the palmar cutaneous branch of the median nerve actually branches off before the carpal tunnel and travels superficial to it. So a patient with carpal tunnel syndrome might have thenar wasting but still have sensation in the central palm.
It's like a wiring diagram. If the fuse to the motor, the recurrent branch, is blown, the lights, sensation, might still be on elsewhere. Dr. Sarah, if you were writing a board question on this right now, what would be the distractor?
The biggest distractor is the adductor pollicis. Students see thumb muscle and think median nerve, but the adductor pollicis is actually innervated by the deep branch of the ulnar nerve. So if the recurrent branch of the median nerve is cut, the patient can still squeeze a piece of paper between their thumb and index finger using adduction, but they can't oppose it.
That is a gold tier tip. Adduction is ulnar, opposition is median. So if they can't make the O shape with their thumb and index finger, you're looking at that $1,000,000 nerve.
To wrap up the academic side, the recurrent branch is a distal branch of the median nerve, C8T1. It innervates the OAF muscles, and injury leads to ape hand deformity without necessarily losing sensation in the fingers.
And clinically, respect the palm. Even tiny cuts near the thumb can be devastating. Test opposition in every hand injury, no matter how small it looks. If they can't pincer, get them to a specialist. Thanks for the deep dive, Dr. Sarah.
Always a pleasure, Dr. Khan. Study hard, everyone.